Okay. So, hello, you guys. Welcome, welcome, welcome. Give me just a moment so that I can actually um, change up my volume really quickly. And that way I won't be heard times two. So, hello, you guys. Welcome, welcome, welcome. Give me just a moment. So, I'm Dr. LaKeonda Jefferson, and I'm the owner and lead therapist at Familial Bond Psychotherapy and Consultation Services. So, today I'm bringing to you guys a wealth of knowledge, series of clinicians from around the United States. And what's going to happen today is we're going to have a discussion about intermittent explosive disorder. And so each one of them will have a specific topic area in which they cover so that you guys can understand more intimately what this particular disorder looks like. And additionally, things that you can do to help people if you notice some of the signs and symptoms that they discuss are prevalent in people who are walking around and having to deal with this disorder on a day-to-day basis. So, without further ado, I'm going to let Marquita, she's in Louisiana, she's going to give you guys some information about what it is in general and what it looks like and how it presents and that piece.
Hello, good afternoon, everyone. As she said, my name is Marquita Turner, and I'm in Louisiana. Um, so we're here to talk about intermittent explosive disorder. Um, what that presents is the failure to control outbursts. Most of the outbursts are usually aggressive. Some can be violent, and there's different levels of intermittent explosive disorder. So, one big thing about it is that it's the behavior is not rational compared to the antecedent, the behavior that preceded it. Um, it's like what people would say looks like kind of going overboard. When someone reacts, um, sometimes in our culture, I hear people say, "Oh, you're doing too much," or when a person may react in a way that doesn't seem appropriate for what has just occurred. Um, and one big thing about it is that it's impulsive. It can't be premeditated. It has to be a direct reaction of what has just occurred. So there's two different criteria when it comes to intermittent and explosive disorder. The first criteria is considered physical aggression and verbal aggression. This is when you are verbally aggressive or physically aggressive toward people, but not harmful. The second one is when you start to damage things. This criteria, you have to have a damaging outburst um, within three episodes of a damaging outburst within a year to qualify for the second criteria. For the first criteria, if you have just a physical or verbal outburst weekly for at least 3 months, then you can qualify as having IED. Um, it lasts about um, it cannot be present in a child under the age of 6. So you have to be at least 6 years old. It usually lasts throughout, if untreated, it can last throughout childhood and into young adulthood. It tends to diminish as people get older, but it can also be present in people like up to 50, sometimes 60 years old, if it's not treated properly or if the person just doesn't develop the appropriate coping skills. Um, so yeah, it can be diagnosed at age 6 and it can last a while. One of the things, like all other disorders, is that it has to be disruption. It has to cause disruption in some place in your life. It has to disrupt relationships or disrupt you on your job or prevent you from being productive on your job, um, anything of that sort. So that's pretty much it. I think now we're gonna have Dominique do
Hmm.
yep.
So the next person is Dominique. So Dominique will come in and she'll talk to you guys about some of the common reasons or common implications that um, this particular disorder over other disorders are chosen, and some of the reasons that it presents in people that have been diagnosed. Is there anything else that anyone else wanted to add to what Marquita had to say earlier about what intermittent explosive disorder is? Okay. Well, if there is nothing else, then I'll introduce you guys. That LCSW Dominique, she's in Indiana and she is the owner and lead therapist at IPCS, Inspire Peace Counseling Services in Indiana. So I'll let her take the floor.
Yes, ma'am. So I'm going to speak about the common reasons intermittent explosive disorder or IED presents. And I'm going to start with, well, I'm an LCSW. So as a social worker, I look as far as like the person and environment. And I thought maybe it'd be fitting to start with the genetics and the biology. So a lot of different diagnoses or disorders present as a genetic predisposure. So especially like if the first relative has the diagnosis of IED. So biology plays a big part in it. Some studies show that males experience symptoms more than females, but that's some studies. Some studies kind of dispute that belief. Um, and it also has to do with your brain chemistry, which is also a part of biology, and your levels of serotonin. So serotonin is the hormone that stabilizes the mood, the feelings, and the overall feeling of well-being. Um, so that's the person, the genetics, the biology, and then we look into the environment. A lot of people, this also kind of speaks to genetics actually, because if you're exposed to violence, so that's where we connect, where if the parent has IED, um, this is a learned type of behavior. So if you're being exposed to frequent domestic violence or intimate partner violence, then you can experience some of those symptoms. Also, exposure to behaviors at home. So if there are frequent anger outbursts from parents or siblings, you're more likely to exhibit symptoms of intermittent explosive disorder. Also, a history of substance abuse, because we know that substance abuse plays a part in, or it changes our brain chemistry. And some people can become angry or explosive when those symptoms or when those substances enter their bodies. Um, and this is something that I tell my littles, like it it's okay to be angry. It just it depends on what you do with it. So you can't exhibit some of the behaviors that you see in the home, such as anger outbursts and things like that. You have to learn how to control those things. Um, but those are the reasons that I have, the genetics and biology, as well as the environment. Dr. J, I'm not sure who has the next spot.
Okay, I was still muted. Sorry, guys. So,
I can also
um,
go in more about different things if anybody has any questions about a person and environment related to intermittent explosive disorder.
okay. So, if does anybody else have anything? So we're gonna let Chanel go next. She's gonna talk about some of the common treatments for people struggling with, the day to day of dealing with intermittent explosive disorder, and we'll see what all she has to offer before I offer any additional comments on it. So I'll let Chanel go ahead and start. And she's located in Maryland, and she's the owner and operator of Self Cared For. It's Self Cared For Counseling Services,
Yep,
not
that's right.
therapy. Hmm.
Right, you said
Okay.
it right.
Yeah. So um, I'll let her go ahead and take over and give you guys her spiel about the treatment, and Tanyetta, you'll go next.
All right. So, some of the common treatments for this disorder is similar to other disorders and other mental health issues. So, talk therapy can be one of those. One of the most common modes of talk therapy is CBT, so cognitive behavioral therapy. So during this mode of therapy, a lot of the times the therapist will talk to you about your triggers, kind of recognizing the signs. Triggers are just recognizing the signs of what makes you tick, what makes you become angry, and then kind of creating a plan on what you're going to do next. And sometimes that plan can consist of relaxation techniques, utilizing coping skills to just help with those aggressive impulses. And then also just kind of changing the way that you think in those type of situations. Another mode that you can do is medication. So there are multiple different types of medications that you can try. Obviously, that would be from either a psychiatrist or a primary care physician that would prescribe these type of medications. So some of the most popular medications are antidepressants, mood disorders, and anti-anxiety medications. Also, another form of treatment that you can utilize is just things that can kind of improve your overall health and well-being. So I'm all about um, self-care. So just kind of taking care of yourself, adopting a balanced diet, getting enough sleep, getting some exercise and staying active, avoiding drugs and alcohol. What else? Managing and reducing stress as much as you can. I know sometimes you can't just take away all the stress, but just kind of looking for ways to reduce that stress, and making time to relax and meditate, utilize mindfulness techniques, things like that. So sometimes just improving your overall health and well-being can kind of help you calm down and improve those impulses.
Okay. So you did cover kind of like what I was going to go into when I talked about some of the additional things that I wanted to add to common treatments. So when we talk about medications that are recommended, we oftentimes, I guess, don't really take into account the importance of learning that some of the psychotropic medications that are recommended for people to take in order to control behavioral disorders and other psychiatric disorders can sometimes be just as damaging as, presenting and having the symptoms themselves. And sometimes, oftentimes, treatment, depending on what type of medication management regimen a person is put on, can exacerbate symptoms. So, one of the questions that I got off the LinkedIn thread, the person asked the question, can adults present with intermittent explosive disorder? And I'm not sure kind of where they got into the conversation, but I'll answer that question and I'll say yes. We do notice that, you know, intermittent explosive disorder is it's a psychiatric disorder that does affect about somewhere between 5 and 6% of the population of adults. And at the end of the day, when you've left it untreated for so long, essentially you're going to have to deal with what's happening, in the here and now. Tanyetta says that the latest data is 7.3%. So that says it's on the rise, right? So at the end of the day, we have people that are struggling every day to deal with everyday distressors, and we're in the middle of a global pandemic right now, so people are triggered a lot more easily than they would have been previously. So when you think about it, it's affecting more and more people every day. So I'll get into, and Tanyetta is definitely next. She'll talk about the implications of what happens if you leave the disorder of intermittent explosive disorder untreated. And so, if anybody else doesn't have anything to add to Chanel's spiel, we'll move forward to Tanyetta.
I do, Dr. J. I did want to, that part was what you answered was part of mine. And I did just want to add that, it's more common in younger adults, like below the age of 35 and 40. And it's more prevalent in those who maybe have not graduated high school or college. And also with Chanel's piece, um, I don't know if you added grounding, but that is something I really see in my littles, like grounding techniques and ocean breathing. And there are so many things that kind of keep that, keep that brain at ease. So that's all I really had to add.
I agree. I agree. And I think she kind of talked about it when she talked about mindfulness and meditation. Grounding exercises are an essential part of it, and keeping yourself in a mindset that understands you are very much in control versus other people and situations being in control of your responses, I think has a lot to do with a person's success in and not only gauging but managing the symptoms that they have to deal with on a day to day. And I know she did mention CBT, but also DBT is a behavioral therapy that has been extremely effective because it gives you more to go off of, and it's very self-reflective, non-judgmental, and approaches things from a radical standpoint of acceptance. So yeah, I'll add
I'm a
that
new
piece.
believer. I'm a new believer in EMDR, and that adds all those things together. It's amazing to me. And I'm probably just biased, but EMDR as well when you say, the CBT and the DBT.
hmm Yeah, because a lot of the EMDR practices are grounded in and rooted in the same practices that are taught in DBT anyway. And Francis Shapiro is very much trauma focused. And so both of these modalities, when you think about it, CBT has a very specific modality that addresses trauma in a very different way. And I think that when people do approach and acknowledge their trauma, you have to do so in a non-judgmental way. And I think that's what makes it effective when you do. Um, but so I'll move forward to Tanyetta. And let's go ahead and talk about some of those implications, Tanyetta. And Tanyetta is she's in, it's Michigan, right?
Wisconsin.
Wisconsin. God, I don't know why I always get those two mixed up. Both of them are extremely cold. That's
Yeah.
why.
Oh,
um, but she's in Wisconsin, and she is the owner and operator of LES. And I think that, I mean, LEC, I'm sorry, on LECS, Life Enrichment Counseling Services.
like
So,
counseling services.
enhancement.
Okay. Mm-hmm.
I wanted to be enrichment, right?
That's
Look, I've given her a whole different brand, you guys. We talked about branding in a separate video with another group of clinicians about 2 months ago, but I've given Tanyetta a whole different brand for her therapy service, her counseling agency. So here's what we'll do. After she's done, I'll let Natasha go on comorbidities, and then we'll move to how the layperson can help with Lana. I just wanted to throw that in there before I finish. But so life enhancement counseling services is Tanyetta's brand, and she is in Wisconsin. And I'll let her go ahead and start talking to you guys about some of the implications if left untreated.
So some of the implications of IED are definitely physical aggression, verbal aggression, I'm sorry, those angry outbursts and physical attacks and damaging property and those kind of things. And a lot of times, because the underlying issues of trauma are unknown or unaddressed, these people present as just angry Black men. So because of that, they're not able to get the treatment that they so readily need and deserve. Another big part of the implications that they're faced with are kind of low self-esteem and self-loathing, suicidal thoughts and behaviors, self-harming behavior. A lot of times they lack social appropriateness due to their reactivity and the inability to emotionally regulate, which makes it really challenging for them in most circumstances. Some of the physical implications are headaches and muscle tension and chest tightening and palpitations and tingling and pressure. There are a variety of different implications attached to untreated IED. And more often than not, the condition intermittent explosive disorder is not effectively treated. Some of the cognitive implications are just that low tolerance, the feelings of frustration and loss of control over one's thoughts, and racing thoughts. So if there is a implication of IED, it absolutely needs to be looked at on a holistic level. And that is what I have. Are there any questions?
I think you did an amazing job at kind of summing things up and handling the part about implications, because here's the thing. What happens is people have a natural inclination to lean towards medication management in America, because it's kind of like the biggest thing for most people when they think about managing symptoms that present, and we say, okay, that this is an issue that's here and we've noticed it. When we give confirmation to it as a clinician, the number one thing they do is run to wanting appeal. And so when you say that it's necessary to kind of take a holistic shift and look at it from that purview, I feel like that's something that's definitely necessary, and more people need to kind of hear that and feel validated in doing so, because I feel like when we don't help them, feel like that's normal, people tend to think that they're doing something wrong, or they're doing their kids an injustice, or they're doing their boyfriend or girlfriend an injustice when they say, okay, well, you just need to do something natural, or you just need to take a couple of deep breaths, or you just need to drink some water, or you need to increase your water intake on a day-to-day, you need to increase the amount of vitamins that you're taking to make sure that you're emotionally well. And so when we say things like that, or should I say, when we hear things like that from the layperson, our cousin, our friend, even if they are a clinician, oftentimes it's easy for people to dismiss it simply because society has gravitated towards wanting the pill, the psychotropic medication. Mm-hmm.
And another thing that I will add, Dr. Jefferson, right quick before we move on.
That's what I was just going to ask, if you had anything to add.
Something just made me think, that's why sometimes it's important that we don't just treat the person, but we treat the system that they're involved in as well. Because it takes a lot of self-control, but also it's easier to be, I guess, tamed when you're in a supportive environment. People who recognize your triggers as triggers and treat them as such versus, scolding you about the behavior, or someone that may be willing to even avoid your triggers, because sometimes triggers can be other people or other relationships. And, your support system has to also understand that once you've reached adulthood, you've been exhibiting this behavior for a long time. And it's not going to just vanish overnight. So you need a very patient and supportive system around you. So, you can't just treat the person. You have to also treat the system. And sometimes it's several systems. Sometimes it's the home unit. Sometimes it's the school unit. Everyone has to be involved when it's considered a child. But as an adult, you have to have patience because this person has been exhibiting this behavior and it's obviously been working for them for some time now. And it's like you're retraining and you have to desensitize them to triggers. And I mean, that takes time. So I just wanted to throw that in there. You always want to deal with the ecology as well as the person.
Yeah. Thanks, Marquita.
I think you're still muted.
Okay, maybe so. So, did anybody else have anything that they wanted to add? All right, so we will move forward, and Natasha is in Florida, and she'll talk about comorbidities. Um, and so Natasha is the owner and operator of Stable Kids Counseling Services, and they are in the Palm Beach area. I don't know what the county is that's near West Palm Beach, but I've been down there and I know it's very, very nice and warm most of the time. So I'll let her get on here and talk a little bit about comorbidity. I know that for a fact when it's hotter, for whatever reason, people tend to have um, levels of hostility and higher levels of aggressiveness in general. So I know that this is probably a disorder that's seen more commonly than not where she is. So we'll talk to you guys in a little bit after Natasha gives her spiel, because I believe that once Lana comes on and she talks about how people can help in the community, I have a lot to say about that.
Hello, good afternoon, everyone. Like Dr. Jefferson said, my name is Natasha. I am in Palm Beach County, so you did get it right. And I am currently located in Wellington, Florida. So it is a pleasure to participate in this conversation with my fellow therapist. So what is comorbidity? It's basically simultaneously two or more presence of either mental health or medical symptoms. So with IED, it has many comorbidities, including mood disorders, personality disorders, as far as antisocial and borderline personality disorders. And also, as Dominique stated, substance abuse is a big one as well. And also, there's a significant percentage of individuals that are diagnosed with IED that has a history of childhood trauma. So that does have a correlation, childhood trauma and intermediate explosive disorder. So as far as the mood disorder, sometimes, when our patients coming in, they're not coming in for IED, they're actually coming in for something else. And often it's underdiagnosed or is dismissed altogether because we're not really thinking that actually the members are not thinking that they're coming in for this specific. They're coming in for some kind of mood disorders, or usually for younger people, if they're in trouble with the law, or if a spouse, maybe they're being threatened by divorce, so they're coming to therapy. They're seeking services. They're seeking services for things that they think maybe depression or mood disorders. And in reality, that disorder or that IED can be dismissed and is usually underdiagnosed. So with this with this disorder, it's often misunderstood. So that's why we want to identify what other comorbidities can be included. So as far as children, sometimes ADHD is also present. It can be prevalent. ADHD, we have oppositional defiance disorders, and we have another one that's often misdiagnosed as well. And usually when we come together and we when a patient or a client come to us, we have to assess to see what else is going on before we can dismiss this diagnosis. Dr. J?
I'm here. I was just, basking in your greatness for just a moment. I think that Natasha definitely did a good job at covering the leading comorbidities for sure. There are, when you talk about some of the medical issues, like I mentioned just a moment ago, the heat has a serious correlation with people who present with intermittent explosive disorder. And the interesting thing for me is that one of the medical issues that we notice you see these symptoms presenting in alignment with is women who are premenopausal and postmenopausal that still have the symptoms of the hot flashes and mood swings and things like that, but they're able to kind of catch themselves. What happens is, because society has kind of normalized and put this negative connotation on women going through the different changes of life and things like that, what happened is those women have been shamed for expressing what happens, on the inside emotionally to them. And so they'll get to the point that they want to hit something, right? And all of that'll be just brewing up in there for so long. And then it's just like, I want to, and then you just stop. And you see that happening more and more often. Now in the past 5 years, we've seen it more and more, because more women are saying, okay, I don't know what to do when I get to this point. I feel like very hot inside, and and those kinds of things. Like, is there something that can help me with this? Because I feel like I shouldn't be exploding the way that I am. Like, I feel like I'm hypersensitive to people talking to me about this and that and the third. And what happens is, I think we live in a society where we have tried to get people to put a cap on and bottle up what they feel about certain things for so long, that when there is a valid level of frustration around things, people just simply don't know how to respond. But they know that some of the things they're thinking about doing isn't appropriate for the situation. And so it changes the way that they act in general in the other areas of functionality for them. But yeah. So did anybody else have anything to add?
I do want to add that it's very important to be careful with diagnosis in general, from a cultural standpoint, and how a lot of people are labeled as angry or as difficult when they don't understand the person in that environment. So if there are different things that are going on, some groups of people are labeled as just being angry when you would be angry at the same things. So I think it calls for a very thorough assessment when it comes to some of these symptoms.
So do you think that that's the reason that, because she did mention a very important one as well, I think it was either her or Tanyetta. Oftentimes, this is one of those diagnoses that is never used. And the crazy thing is that people are definitely in alignment with suffering from the issues of intermittent explosive disorder, but oftentimes it's overlooked simply because many clinicians aren't versed in every single diagnosis, and they don't open up that book often enough and see themselves looking through, reading through, just in their lay time, right, to kind of give themselves a full view of what this disorder particularly presents like, and what that looks like when people are struggling with this versus other issues. So other diagnoses are sometimes overdiagnosed when actually a person is dealing with this particular one. Do you think that that's the reason? Because people feel like, well, I don't know if I have enough to go off of, or I don't know if this is a cultural or, family of origin kind of shaped behavior. Do you think that that's why people avoid diagnosing in this area?
I think it takes some time to kind of figure out these issues, because you can't just say, this person has IED and you don't have everything you need. So I don't know, maybe it's an afterthought after they've already diagnosed and hey, this fits better. But also with the labeling, we have to look at the cultural perspective, and how we see people, right? Kind of like the fear of the unknown. So I might be treated different when it comes to or versus someone else that has the same issue, but I'm going to be more angry because you're treating me a lot different. So then I'm going to get labeled. And that's just the societal standpoint. And I think that's more so what I meant when I was just like, be careful with the diagnosis and understanding the person and not labeling them with something and then letting that kind of marinate with them like, oh, well, I'm just angry, and you don't want it to also become a label that they're just like, it's kind of like zodiac signs. I absolutely hate when people blame it on their zodiac signs. Do not, I don't like, well, I have IED, so this justifies my behaviors. No, no,
But I
ma'am.
think it goes
Right.
off of helping people to understand that a disorder is not you, it's not the person. And so a disorder is the disorder. And so when people talk about labels, I feel like that's what psychoeducation is for. So when a person comes to you as a clinician and then you find that, this is what's in alignment with what they're dealing with every day and what's throwing off, their behaviors and their emotions and the various functional domains that are affected by that, I feel like you have to kind of educate them on what the disorder entails. So the disorder itself, not the person. Because so a person isn't a schizophrenic. It's a person who's dealing with schizophrenia. And so when we say that this is a label, I think you have to look at it from a pragmatic standpoint. So when, as a medical doctor, if a person comes in and they ask me, they tell me they present with certain symptoms, and before I send the labs off, it definitely looks like the discharge that's from gonorrhea, right? Nobody's going to question me about putting that label out there when I write that prescription. You want to know why? Because I know what this particular disorder in a human body looks like, right? And so if that's my prognosis prior to me getting that confirmation from her labs, she's going to take the medication because as a clinician, I'm pretty versed in seeing what this look like. I know what it looks like. I know what it smells like. I know for the most part what it behaves like when it's introduced to this variant. And so I can give a pretty good synopsis of what's going on before I sit with her labs and say, "Oh, yeah. That's just a confirmation after the fact." So I think when we have people saying there is an issue with labels and they're coming in for therapy, you have to give them the psychoeducation part that helps them alleviate that mindset where they're like, okay, well, I don't want to be IED because you're not IED, you're not ADD, you're not ADHD. You're whoever, and you just might be dealing with this, but as a result of us discovering that today, this is how we're going to mitigate those symptoms. And so then you can get back to living your best life.
But I feel like so many people are so much more comfortable going to a medical doctor and getting um, those physical issues taken care of. Like, I'm cured, so they don't become gonorrhea. They had gonorrhea, it's over. But when it comes to the mental health stuff, nobody wants to own that. Everybody just wants to deny it and say like, oh, they're just labeling me, or they don't want to. And I also think that our society has made it so that people just need to eat it. People need to just deal with it. Pick yourselves up from your bootstraps. What are you doing? Like it's not that bad when there I get what you're saying too, that it's not about the label, it's about treating the symptoms. So now you're seeing the symptoms from this disorder. So what can we do to help with that? But I just think our society just doesn't want to do that. They either want to ignore it or they feel crazy, so they don't want to go and talk about it. They just want to kind of make it go away, make it so that people don't see what they're struggling with on a day to day. And I
And
think
I agree.
Dominique, my fellow social worker, we're all about seeing people from, it's
Yeah.
not just about the person, it's about what's going on in society, what's going on in that family, in the community. It's so much more than just this one person. This one person wasn't born and then they just exhibited all this stuff. A lot of things have to do with it.
I,
Exactly.
And
But
then
you know what?
another thing that I wanted to add is that
Mhm.
people tend to there's a lot of other, like we were talking about why it's not so often diagnosed. There's a lot of other conduct disorder diagnoses that we use a lot more frequently than IED.
Right.
However, IED is a little bit more specific, and a lot of times it's not diagnosed because sometimes um, the behaviors and the way that it presents so often sometimes that we see it as normal, and we tend not to track normal behaviors. So when it comes to diagnosing IED, you have to be able to say this person did this for 3 weeks straight in the month of January, then she did it again, and this, like, most people, if it's a common behavior in the household, the mom's gonna say, well, he just cut up yesterday. And it's like, okay, well, when was the last time before that? Well, he did it the day before too. And he did it the day, they're not actually tracking. So it's hard for me as a clinician to say, do I really believe that he did it every day? Or is it so common that they feel it may have occurred every day? So sometimes we're not working with children or adults long enough sometimes to see the behaviors occur enough times and the occurrences to say this is specifically IED. We tend to, and I won't say we, but some therapists
Yeah.
tend to put it under conduct disorders and
Mhm.
tend to treat the behaviors. And then sometimes you have to look at what insurances will pay for. That's another aspect of it. So we tend to overuse certain common diagnoses for a lot of different reasons. And again, I won't say we, I'll just say therapists in
But
general.
clinicians in general, and I agree, and you definitely were honest when you said that. So in diagnosing, when you're doing the information collecting portion of the diagnostic interview, which is supposed to be the first session for people when they come in, and what I've noticed is that, and I say this the way I said it because I notice on all these different platforms where people are getting reduced rate therapy, some clinicians are jumping right in with them based on the symptoms that have been reported, and just working with the symptoms, and that's it. I feel like that's doing an injustice to society. Even if you feel like you don't have the adequate payment to do a complete BHA, you should still be doing it. And that's the reason, because if we're collecting the right history, the proper history, even if it's informed by trauma, we need to be seeing that this person has responded aggressively, overly and disproportionately aggressive to situations where that's not the norm in their culture, because that's what you're diagnosing based off of, not your own biases, but the consumer, what they consider to be a problem for them, what their family system considers to be a problem in the family system, because they're looking like, okay, well, this is what I notice is agitating this person, and when this happens, they respond so abruptly and so quickly in a negative way that before anything can be explained, and that's the indicator for this disorder for people that are watching, they react in a way that's so aggressive and so quickly they do that nobody has a chance to justify anything. There are no questions asked. And when they do it in the aftermath, they're even sitting with the question of what just happened here. That's how you know that that's the disorder you're dealing with. Intermittent explosive disorder doesn't look like a lot of other disorders, and that's what separates it from conduct disorder. And I feel like a lot of people just don't, they've not seen it enough. And when you've not seen it enough, clinically, because you've not done that really in-depth investigation in the interview, you might not know how to pull from the consumer what it is you need to pull from them. And like you guys said, we normalize a lot of things in black culture, especially, that is not normal. And we have to stop doing that as a culture of people. We have to stop saying, oh, well, he's a hothead. He's always been a hothead. You
period.
know, right? or, she just on her period. Because that's another thing. What do you hear guys say all the time? Like, oh, you must be on the rag. Like, I hear these young people saying it all the time. And at the end of the day, it doesn't mean that, because some people are just very emotionally reactive and they don't have the ability to control those impulses to respond negatively. But so,
I'm saying period as in period. That's
oh,
it.
I
That's
know.
all. Okay.
I
I
know
do
that.
want to add though, like when you said that we're doing a disservice to society, nail, hammer right on the head, because we can't do lazy therapy.
Right.
Can I have our clients coming in? Well, so and so diagnosed me with this. Like, I'm the expert. You're the expert on your life, but I'm also the expert in what's going on. So
Right.
let me assess. Don't just come in here and say, well, I'm bipolar and this is just why I do everything. No, you are a person that is struggling with a disorder, and you're not just going to come in here and tell me everything it is. I can go and I can staff with whoever has diagnosed you. I can get all your paperwork, but it's a disservice to do lazy therapy. And I
Mhm.
think that it's a great frustration, especially in community mental health. But as clinicians in general, it's a high need. We all have a lot to do. We have high caseloads, but there's no room for lazy therapy.
Yeah, I agree. I agree. So
And
without, oh, you have something else before we
I
get to?
did, sorry,
Oh, it's
I
fine.
did, because Chanel talked about oh, I'm forgetting the last thing she talked about, but I jotted down to talk about the past, like how you can resolve a prior diagnosis, or you can resolve a current diagnosis. We don't have to be stuck in these, we don't have to be stuck with these diagnoses.
Diagnostic classification is not forever, and yeah, that's what it's about.
And there are there are some things that, this is just what it is, like having a intellectual disability. But there are some things like intermittent explosive disorder that can be resolved. You just have to put the work in. So I can't do lazy therapy, and you can't do lazy client or patient. Like, it has
Exactly.
to be a working relationship so that you can be like, okay, look, I struggle with these things, and now they have been resolved because I've been meeting with my awesome clinician and we've been doing this, that, or the other. Like, it does not have to stay and it does not have to stick. And I think that that's an important thing to bring up about IED, because it doesn't last your whole lifetime unless you just stay complacent in it.
And
Exactly.
I see so many clients who have so much hopelessness and helplessness, like they don't see a light at the end of the tunnel, so they get labeled with these things like, this is just who I am. I got a lot going on. I'm angry. It's just me. And it does, and you're right, it doesn't have to be this way, but I think so many people just think that it does have to be this way.
Right.
I'm just angry. I'm just worthless.
And I want to add, like Dr. J said, basically, it's all about educating the client. If they're miseducated, it's all about miseducation. That's the reason that they believe that they're going to their grave with this illness. And most of it are manageable if they seek the right treatment, get on medication, they can be treated. You don't have to be your disorder or your disability. So that's where the education comes in, so that we can educate our clients that yes, you have been diagnosed with this, but you're not this diagnosed, and you don't have to, your life doesn't have to be in that kind of disorder. You can manage the disorder and live a normal life. Or not normal, but you can have challenges, but you can still live and be productive, and not have that disorder define who you are.
Right.
I always say there is no normal.
Well, self-defined. I think people have to
Yes,
find their norm,
Yes,
their norm that works for
right.
them.
sorry.
Yeah.
You don't have to have societal standpoint of, well, this is what I have to do. Like, this is normal. No, I can make anything normal. Normal is subjective. I can say that it's, you know, I can
That's
say that it's normal to stand in the front of the window and scream every day. That doesn't make it true.
right. And
True.
that's
I say pragmatics. So
yes.
it has to be able to be something that makes sense. It has to be sensible for you, person, place, and situation. And so I think that we have to, our job as the clinician is helping people define what's normative and acceptable, not only just by society, but also by their own basic rules of operating in the various functional domains that they're committed to and they're engaged in a regular, on a regular basis. But yeah.
A lot of times, I'd like to add that sometimes people are struggling from the things that they're struggling from because of forced normal,
Hmm.
societal norms,
Yeah.
things that don't feel right, but everyone around you is telling you that this is how you're supposed to be. So a lot of people's behaviors present because of the forced norm.
Yeah. But so we'll get into how the layperson can help, presented by Lana, the voice, and she is the owner and operator at Immerse Counseling. So I think that when we talk about before she kind of gets started, when we talk about how the layperson can help, we're talking about things that you can do as a person who's watching this video who is not a clinician, or you may be a clinician, but the most important thing I think to take from this is, even if you are a clinician and you're one of those clinicians that like to use the clinician role as a cop out, because I see that happen often, very often. Oh, I'm a clinician, so I can't help you. You know, you're my sister, so I can't help you. You can always hold space for family members. You don't have to do it professionally, but you can definitely help. And so I feel like everybody in society is interconnected in some way, and we have to learn how to do our parts and to be intentional in doing our part in society. And so Lana will talk to you guys about some of the things that you can do to help. Maybe some of the ways that you could recognize that this is a person that's in need of some help or assistance, and and alternatively, hopefully, she has some things that are contraindications on her list, or things that you want to avoid doing. And if not, I'll add some, and I'm sure everybody's got something. I'm sure she can think of a couple of things that you definitely don't want to be doing. um, so without further ado, I'll let her get started. And she is in North Carolina, right?
Yes, I'm in North Carolina, Charlotte, North Carolina. So a lot of you have talked about some of the things that I was going to talk about in general. So thank you, Marquita, Tanyetta, Chanel, Dominique. I was going to be talking about what you can do as a layperson. And as Marquita had told you guys before, this is a disorder where there is no premeditation, okay? It could be verbal or it can be physical. In a physical situation, in a crisis like this, if the person is in a crisis that or a loved one that you have, you need to be safe, okay? Because at the end of the day, you want to help the person, but you want to be there the next day. So if it becomes something where it's a physical situation, you need to make sure that you are safely in a room, you don't have any knives, anything that can be of hurt to you or others in the room. Sometimes when I've seen someone explode with intermittent explosive disorder, things can go pretty left as far as walls, holes could be in walls, things can be thrown. You want to make sure that you have all your babies out the room. Anybody that can get out the room can get out the room, because these kind of episodes only last for a certain amount of minutes. You have to understand that. And as we talked about before, it comes out of nowhere and it's disproportionate to what has actually happened. So the example I'm going to use is, let's just say you have the trash man, and the trash man, you know, we all have a trash man, and he comes and he takes your garbage, and the garbage can could be at the neighbor's house, because sometimes they throw it wherever they got it, okay? Or sometimes it could be at your place, but then the other trash can is down the hall. So let's remember that example, okay? Now, let's just say you're one of those people who do have this disorder and that has something about that just triggers you, and you just go off and you get into a cussing and a stomping, or you come back inside and you're with your spouse and, you know, it just triggered you and you become violent, not with your spouse, but you throw things or you slam things or, you know, these kind of things. You want to make sure if you're someone in the room, you need to be safe. Doesn't mean that you don't want to help. You just need to be there to help them when they have calmed down and they're not triggered. We also talked about education. That is fundamental in all that we do. And the reason why I say education is because it's a good way to model for the person who actually has the diagnosis. Understanding the person's diagnosis, understanding how you can be a help is invaluable. When we also talk about education, we talked about support systems. I think Marquita talked about support systems and having those support systems, and not only thinking that this disorder has to be an isolated incident. If you have someone, let's just say a child who has this disorder, and you have cousins and, you know, family members, sometimes it can be intimidating talking about this and saying that how my son or daughter has this disorder. But on the other side of this is, if they're in the home with someone and they have an outburst, this might not be seen as a disorder. This might just be seen as, oh, your child is rude and I don't want to see them in my household. You know, they need to know what's going on as far as the disorder so that they can keep their self safe. They can calm your child down and understand what needs to happen next. So we have to get out of the mindset of, I can handle this all on my own, because in the past, a village raised a child. So if this is the case, then you need to be able to communicate what is going on with your, as Dominique would say, your littles, right? If it's an adult, I would hope that you know to let your spouse know about this, but also your family members. So that way they can help you when you have an outburst, or if you have an undesirable reaction. Another thing that we talked about is triggers. Knowing your triggers, but not only that, but the person that's helping, knowing your triggers, because sometimes we don't understand what's going on because it's so premeditated, unpremeditated, that you just don't understand, well, why were we just fine just a minute ago, but now you're just yelling and screaming? That can be very concerning for anybody. So understanding your triggers is also something to think about in a crisis, because when somebody says something in a verbal rage, you're starting to say, well, is it because I'm not a good spouse? Is it because I feel like I'm not a good mother that this is happening? This constantly happens. And you can believe it or not, those kind of questions happen to a lot of people when you're faced with a crisis with someone who has a disorder. So knowing your triggers so that way you can effectively help the person goes a long way. And also, it also makes things better for everyone. Knowing the person's triggers, like for instance, the garbage cans. You know that upsets your spouse, or you know that upsets your child or teenager. So one of the things you can do is use empathetic statements when they come back in to kind of deregulate their emotions for them. Say, hey, I understand that those garbage cans were, thrown all around and you had to go and get them out from the neighbor's yard. I'm sorry that happened, but maybe next time we'll go out there together when they're taking out the trash, so that way we can just pull it in together. These are ways that you can use empathetic statements to kind of bring down or de-escalate the person before they get to that point. So learning empathetic statements are good to use during a crisis because it makes the people feel validated, and also it helps to regulate their emotions and also to de-escalate during a crisis. Another thing that we talked about was medications. Now, medications, we talked about comorbidity, and some of these medical medications, we all talked about the side effects. However, if you're on medications and you are having a youngster or little, then you might need to know that you are their biggest advocate, okay? When I say you're their biggest advocate, if there's medications that are not working, then you need to speak up for your child, because there are going to be times when the medications aren't going to work for you. And so you need to be able to say, listen, I'm noticing that there's things that's happening and we've been having a lot more crisis in the home. We talked about, Marquita talked about symptoms and logging the symptoms. These are all things that you can do when you have a spouse with this, and say, hey, well, I've been noticing that you have been having a lot more outbursts, and I know that this is something that you don't want, and I know that you need the support, and I would love to support you. Do you think I can come with you to your next doctor's appointment, and we could talk about some of these triggers and how many of these triggers that we're seeing multiplying throughout the month? So these are some things that you can do to kind of help in a crisis as just a layperson. But the fundamental thing is to educate yourself. Educate yourself like you've been doing right now with this series, to find out more about the mental health disorder, and then how you can help a friend or a family member.
Okay, so I have typed in all but one of the questions that I received from you guys from the Facebook group, the Red Table Talk group. And I'll let some of the clinicians kind of jump in and start answering some of the questions as I ask them out loud. Um, and I will finish typing this last one up. So you guys can kind of look at the list of questions and start answering them.
I see one that has to do with the police interactions, and if that could have something to do with IED. And, I always say I'm not, even though I'm a clinician, I don't like to diagnose people that I've never met before, but I can definitely see how, police officers could have this disorder as well. But at the same time, I think a lot of what we're seeing with the police officers, especially when it comes to Black men and our men of color, is they're just afraid. So they might think that they're doing the right thing by kind of getting this bad person off the street just because of their their horrible preconceived notions of what Black men are and what they represent. So, yeah, it can definitely have something to do with that, or it could just be, no, it's not. It's immediate because they think that they need to take this bad person off the street.
So can I jump in here with that,
Mhm.
please? So that's when when I talk about education, I'm not sure if this is something that is in every state, but in Charlotte, North Carolina, we do obviously have CIT police officers. These police officers are trained in mental health stimulations, and so that way they understand how to interact with someone who has a mental illness. A new program that we have here in Charlotte is called Safe Outcomes. And so when I was talking about education and modeling that kind of behavior for everyone in your family, some things you might want to think about is there are in certain states programs with the police officer where you might be able to put the information down, let them know that, hey, my son or daughter has intermittent explosive disorder. So if you do come in contact, it's because if they're in a situation, it's because of this. So that way they know how to, one, come to the person and try to calm them down because they've learned these techniques now. And then also they're aware before they even come into actions with them. So there's no negative interactions. There's no labeling. They know what it is.
So I have a little bit to add. The question states, so these police interactions are due to IED. Um, if I can get some clarity on that question, I'm not sure um, if they're saying the person is reacting out of IED or the police is acting from an explosive manner. But I'm going to take it from the other side, and I'm going to again kind of speculate that we're talking about some of these possibly racist interactions or somewhere where police are actually like harming people. Some police can be, suffering from IED. Um, those are things that need to be addressed in occupations when you deal with the community. Um, I work with the community often. There are a lot of things that I see that catch me off guard, and my first impulse is probably not the right one as a professional. So sometimes, um, as professionals, so from the standpoint of the police, you know, when you react in a way that is what the definition of IED is, over exaggerating or too much for the current situation, such as possibly harming someone or killing someone, um, that may have been doing a misdemeanor crime. um that's a total different spin on the question. But sometimes, I just want to add that being a professional does not exempt you from exhibiting IED, and being a professional does not also promise that you're going to get the proper treatment. So these are the type of diagnoses that we may need to look at a little bit more when dealing with professionals that deal in the community as well.
Okay, so he just responded, and I typed his response in there. He said he means when, I'm not sure what he means by we. I'm assuming he means like people in general that are going against law enforcement. He says when we act out with the police quickly. So
People fear. It's a fear of the unknown, and that's on both sides, based on history. Um, so I think that you have to think about those things, and I think that's where the cultural considerations come in, and not in a sense of just cultural, but just like understanding both sides. Like I sometimes you cannot just up and think about these things when you're in a potential dangerous situation, but continuing to talk with people. I know a lot of officers that I talk to and explain different things to, because we're friends, and that's just how the conversation goes. People want to seek to understand, and both sides have to be willing to listen and understand each perspective or each point of view. So you have to listen to hear instead, or listen to understand versus listening to respond.
And then I would add too that, I can definitely see it where somebody is acting in a way where, it's not rational. They're just overreacting to a situation with the police officer. I could see that. I could also see all the trauma that we as a people are going through, and different other situations where they're fearing for their life. They're seeing what's happening in the news and to other people, and they start to maybe react in a way that, they may be able to react better in that situation, but at the same time, people are afraid and they don't know how to interact with police officers sometimes, and they're scared. So I can kind of see it going in a lot of different ways. I can definitely see them suffering with this disorder, and I can also see people just being afraid and not knowing how to deal with it.
something that stands out for me and something that kind of comes to mind as you guys are talking about this. I know that I'm in a different generation than most of you. But I think that Natasha and I think Tanyetta, they can relate a little bit to kind of what I talk about when I talk about the impact of the Black Panther organization way back then on the community and the black community. Not only the black community, because you would have to been a part of that era to really understand their impact. But a lot of people, I think, black current millennials, young black people, think that this party was a different about a different thing than what they were about, but there was a lot of cohesive effort put towards their agenda, and it was about bringing all people together regardless of race and helping the disenfranchised community. And that didn't look like just the black community. It still doesn't today. And I think that we have to take a similar approach in these times, because that the only reason I feel like it was a failed attempt back then is because the system behind everything was majority racist. And so now the system behind everything is majority curious. And I feel like, he was before his time. And I think that now is the time to organize to help people adapt more pragmatic responses to dealing with law enforcement, and more sensible means of not only dealing with law enforcement but their brethren when in times of distress. And I feel like it starts with us as clinicians reshaping the mindsets of people who normalize these types of behaviors when it starts, as because this is just kind of like the cusp of what the real issue is in society. When we say that it's okay for people to be a hothead, it's okay for a person to present with, symptoms that say that they're easily agitated, because we understand that they're easily agitated because people piss them off, or because people aren't necessarily doing things that are a part of their agenda, etc. So we have to stop being so dismissive as a culture of people, and we have to do the things that are going to allow us to seat ourselves in a different position so that we can be responded to differently. And so I feel like that has to happen on the community part before it does on the police officers part, simply because the police officer is a small portion of the society, same society we all are a part of, and they're charged with the responsibility of trying to protect and serve us. And I say trying because at this point, with all of the trauma that we've suffered through, without just the implications of a pandemic, but also with police brutality in the last couple of years, the way that it's just been portrayed and put out there, I think that we have to take into consideration the fact that the community has definitely organized an assault on the police departments in various states. And that's been a very dangerous thing. And even before then, before it really took off, it's been like that. They have a very dangerous job, and we have to respect the fact that these people that are charged with protecting us are not everyone who does us injustice. And so that will help them, as we model that behavior, reshape the mindset that they have on us as people in the community. But so with intermittent explosive disorder, this is an area where police officers will struggle with maintaining with their charge, with trying to do their job, because apparently if this is not a premeditated type of response organism for people, it doesn't matter if the police officer is doing everything that they can to help out this individual. That person has no ability to control their impulses, and so they will present with behaviors that would make people respond to them in a volatile way before they even know what they're going through. And so I think that that young man he raised a very loaded question when he typed that one in today, but I feel like it's a lot. So I'll let you guys kind of finish up answering the rest of these questions. And I appreciate those who caught us live, that are watching from the Facebook groups and that are watching from the YouTube page and the Facebook pages and things like that. You guys are amazing. Continue to have the questions come in, and then we'll type in responses from time to time after the feed ends. So I'll let you guys go ahead with the next question, or if you guys have anything else to add to that one. I'm gonna read this one out. This one was funny to me. And I mean, that's nothing against the person who typed it. Like, I guess I'm entertained by how you typed what you typed. She said, "I know this is my man because I make the same breakfast every morning, and some days out of nowhere He just is mean about the way the food tastes.
Be careful, okay? Um, because I don't think we went over every single diagnostic criteria, okay? So
Right.
don't be the expert in your man's life, because there's a reason why therapists cannot, or clinicians cannot do services.
Diagnose with right.
They
We can't
cannot
diagnose
be,
with a
they
snap.
cannot see their partner, their cousins, none of that,
Hmm.
because it gets a little
Bias.
murky. Things get a little tense. Like, so just be careful.
And I always say, when you're looking for something, you're gonna find it. So if that's what you're looking for something to be wrong with him, and now you just found something that makes sense to label him.
Because we went over differential diagnosis, and there are other things that we didn't touch on, and I can't wait to do this again over, maybe one of the differential diagnoses. But still, don't narrow down and be like, oh, okay, it was this week, now it's this.
Yeah.
Be careful, don't make your relationship rocky.
But I do think that maybe you guys need to see a couples therapist.
In the beginning, like Dominique was talking about, remember some of the criteria that I said, it has to exist weekly for at least 3 months. So if it's just every now and then that he's upset with your breakfast, and then his behavior or his reaction has to be damaging in some way, verbal or physical damage, to qualify for criteria 2, and it has to occur at least 3 times in a year. So that's what Dominique is talking about when we say, just because we see the behavior, we can't just say, oh, that's IED. It takes a lot of other things to just give such a specific diagnosis, not just, you won't eat my breakfast.
And
But
we
no,
need to be
she's not
accountable.
dismissing you. She sent me a message.
Right.
She's not
Look,
dismissing you, but what we're saying is that, like I mean, not Natasha, but Marquita was saying just a moment ago. She was saying that we can't. You have to look at how long this has been happening and what exactly has been happening. So, and then some people, even though we talked about the fact that it has to be sometimes physically damaging, sometimes it's just emotionally damaging to the person. That's the part that we really didn't talk about. And so people and that's one of the key symptoms that I've seen people present with, where they get to the point where they want to blow up and then they just don't, they're boiling. And so they may not hit something, they may not hit someone, but they're like, "Ooh," and then it's just over. And then standing there confused.
but
Sometimes it presents like that, but you have to look at everything to make sure that they meet enough of the diagnostic criteria that's required for us to assign that particular diagnosis. But you can do that through a couple therapists.
defensiveness, we have to make sure we're not being defensive. Like, I tried one time, I tried to try some ramen noodles. I tried to make some ramen noodles, add some things like I see on YouTube, and my family did not respond how I wanted to. And I'm just like thinking, they ungrateful. And I tasted, I said, this nasty, like, so making sure we're not being too defensive, because maybe we try something new and he didn't like it, like just giving the benefit of the doubt. And that's kind of what popped up, because I was thinking, I was like, I thought I was getting it, I thought I was chef, but like, no, sis, you're a social worker. But no, not dismissing things. And Dr. J, write this down, because being a therapist in relationships, because this is not something that the person who typed this comment wants to be. Because it's hard, because you don't want somebody asking, well, how do you feel? And you got to separate the two. And I'll let the other ladies answer the rest of the question, but those are just my thoughts when I hear it. But I love
Yeah.
this comment out of all the ones you wrote.
Yeah, absolutely. And I do think that she's speaking for a lot of other people too, because I think that other people kind of see different diagnoses and they're saying like, oh yeah, my man got that, my girl got that, we need to go get her help. But I see, and that's why I keep saying, and I think people get so irritated with me, I do not diagnose people who don't come to my office to get diagnosed. So a lot of people will come to me and say, yeah, my problem is my girl, and this is all the stuff that she's doing and what she got. So I can go and tell her what she got. I'm like, I'm not.
Right.
It's a person, it's a whole person with a whole different type of like situations
Then they
and
calling you,
family. Yeah, like
knocking
no,
on the door, like, you said
no,
I had this, that, and the other.
right. I'm
No.
I can't do that. And that's not fair to the person. There's so much more to people than just the few things that you see is going on with them. Like even your husband or somebody that you see every single day, there might be some stuff going on that they're not telling you. So you can't just kind of box it in like that. But I do know, like a lot of people feel this way. A lot of people throw out that the disorder bipolar. Oh, you just bipolar, and a lot of people don't even know really what bipolar is. So you just got to be
Right.
real careful. That's all.
Right.
Exactly.
I agree. Even with the internet, there's so much information out there, and it's tempted to self-diagnose yourself and go online and Google this, Google that, and well, I experienced this. Well, my sister experienced this. It is very common that even the children that I work with, they're doing that. They're diagnosing each other and themselves. So it is.
Mhm.
Yes. So I wouldn't recommend that because they meet one criteria, and you feel like he's diagnosed with this. So definitely see a professional. And like the other lady said, maybe have a conversation with your husband or boyfriend and see if they're willing to go to therapy, and hopefully, and maybe that person is not self-aware that they're that critical to you. Have you sit down with them and talk to them and explain that that may hurt your feelings, or you don't like the way they criticize your food? Sometimes it's just a simple conversation as that. Otherwise, sometimes as well, it may take therapy to get to a point where you're both comfortable.
I agree with that.
I think that Natasha was speaking to boundaries. What we teach people how to treat us. And my family, you're gonna take what you get. Because it's not much when it comes to cooking. So, like I think that it's a boundary that has to be set or put in place. And another thing that Natasha was talking about with that self-fulfilling prophecy. If I keep saying I have IED or bipolar disorder or antisocial personality disorder, it's going to manifest because I'm
Because
looking
you're
at
looking
these
for
diagnoses.
something. Yeah, that's
Yes,
what you're
I'm
looking
trying
for.
to depict these things so I can convince whoever or convince myself, and it's not good. So we need to go over again before this end where everybody is, get those referrals running. You know what I mean?
Yeah.
Like,
Exactly.
Like how you
Yeah,
think, Donna.
yeah.
Right.
We might have to move
Right.
on to
And
the next one because I don't want her to feel attacked.
you
no,
know,
not at
but
all.
even
Not at all. I used to.
she already felt attacked. She
I
felt attacked
know.
already, but that's okay. And that's what I told her. I'm like, we're not necessarily dismissing you. It's just,
Mhm.
it's a
No,
lot. It's a lot to it.
And I appreciate her even saying that because I know so many people seriously in my life who diagnose people that they with, and you speaking for the rest of them that can't speak up. So I appreciate
this. I wanted breakfast when you made that comment. I want your breakfast. So, just it's not a defense, it's not a attacking type of thing. It's just more of that initial thought. Like I pretty much just stated my initial thought in that, situation, because it could be a rocky relationship if we diagnose. Like I'm not gonna sit here and diagnose my kids or anybody because it makes for our relationship to be a little, are you being my therapist or are you being my parent? So I would just separate them.
Right. And I would thank her for this question, because it's actually a conversation that needs to have, and it may save other people from doing the same, diagnosing their partners or their family members. Like we all said, there's different criteria, like Marquita was saying. It's just not one thing. It has to be, they have to sit and have a professional kind of go over what's going on, have a whole history. It's a lot in the process before we diagnose someone. So we can't just say because of one thing, you have this. It takes a lot of consideration, a lot of questionings, a lot of assessment to get to that point.
Right. And so the process of being a clinician is not something that people can pick up from the internet. I'm sorry, you guys, but I'm just going to be honest about that. I know that a lot of people think that because the internet has so much of an abundance of information that you can go out there and you can do what the work it is that you feel like we do, and you can get yourself together. It's just that's just not true. You need to stop telling yourself that. And I talk to people a lot about telling each other and telling self pretty little lies to be able to get over the very huge atrocities that life throws at us or whatever. So don't do that to yourself, because you'll be doing yourself an injustice. Do yourself the right justice and get yourself a clinician, even if it is on one of these websites where your reduced rate is what you're paying. And I want to urge clinicians out there, yes, I'm going to step on some toes, and that's okay. So I want to tell you guys that if you're taking people on with that reduced rate therapy via Open Path or any of these EAP programs that you're using, do not do an injustice to the people that you are serving by giving them a limited 50-minute session when you're first taking them in. Do a full BPS, even if you got to take that, you got to take one for the team and write it off. You still need to give them that 2-hour session, because you need to be doing the proper work of diagnosing before you see people and be working on issues, because you make life harder for other clinicians that are thorough and that are doing this job the right way when people are out there and they're getting that and they feel like that's adequate therapy, and they come out and they're like, well, I didn't really get anything done, but so therapy doesn't work. We have to do our job and do it efficiently if we want people to move forward in life and be the best versions of themselves that they can be, because it's about helping people and not hurting people. But so that's that one. The next question is, I want to know if some people have this and don't know it. Who wants to take that one?
I'll jump in and say it's very possible. I think we kind of talked about this earlier as well. We were talking about the conduct disorder and maybe the ODD. We talk about comorbidity, which is when you have a few diagnoses that may exist at the same time. So it's very possible that IED may be hiding inside of another disorder, if that makes sense. It may also be very possible that I think I may have said earlier in this taping that sometimes it's just not properly diagnosed because it is so specific.
I do feel like sometimes it's not properly diagnosed because of the specificities of it. But I also feel like sometimes people just don't look at it. They don't look to it as a diagnosis because they don't feel like people are struggling with this issue. And as a clinician, if they're not seeing something as a prevalent issue in society, they don't naturally go back and kind of look at all of the possibilities of what may be presenting in front of them. But I feel like that's kind of like something that we've got to get in the habit of doing. Because I'll say that too for medical doctors out there. Yeah, I'm stepping on all of your toes, and that's okay. Because sometimes you don't open up that desk reference fully because you feel like, oh, okay, well, yeah, this is this, and this, and even that's the reason that coronavirus was misdiagnosed so often before finally they got down to it and said, okay, yeah, this is something new, because you're just looking at the symptomology that you're familiar with and you're going off of that. You're not looking at the expanded symptoms that people are presenting with. And I think sometimes we got to just do a better job of fully assessing the situation.
I want to put one thing in perspective for people that can see us. This book is almost as thick as my grandmother's Bible that she kept on the coffee table
but it's 300 home. And some pages long.
There are a lot of diagnoses, and sometimes it's easy to missed something, like as far as like IED versus conduct disorder. I mean, they are in the same, it's in the same, what, impulse control, conduct disorder. Those are all in the same chapter. Not,
And
it's not a
actually, that's a
chapter.
good thing that it's now grouped in that way. But when you're sorting through 300 some odd different pages, and if you look from front to back of those pages, it's 600 and something, almost 700 of content, raw contents in there. Some people don't want to go through the whole thing, but I think that's why you have like a table of contents, and you have like this time to sit through and look at what you feel like this particular disorder is, and then go back with your notes after the session, after you do a BPS, and kind of say, okay, what are some of the other options right here to do your quick rule out. So I think that you just have to be doing, I feel like people just have to be doing the work, and yeah, it's work, but that's literally what you're getting paid for. So, if I'm the patient on the other end, don't misdiagnose me with cancer, and all I have is, a little bitty mass coming here that's non-cancerous. You know what I mean? Just because you don't want to flip out.
I agree, Dr. J, because you can still have it and have ADHD. You can have it
Yeah.
conduct disorder. You can have it oppositional defiance disorder. So even though they overlap, some of the symptoms overlap, but you can still be diagnosed with
Both.
Conduct disorder, antisocial disorder, and any ADHD, and still have intermediate disorder.
Mm-hmm.
So
And then
absolutely.
you're talking about unjustifiable responses too. So when people have severe trauma and they're responding as a result of those trauma triggers, then that moves out. That's your rule out right there. So for clinicians struggling with that piece, I know it's a lot of new clinicians out there, and when I do my clinicians master classes for people coming out of school and things like that, the number one question they ask me when they're covering diagnosis is like, okay, well, how do I know it's this and not this? The best way to do that, the best way to get a really good clinical conceptualization of what you're really dealing with, is to know that you're doing the rule out work. And so what I say is, don't look for something, look for nothing, and allow everything else to manifest on the table in front of you. And so that's just kind of like you doing adequate work, and taking care of what needs to be taken care of on the clinician's part. And I think people have to be more open to what they may be dealing with when they go in with and sit with a clinician, because we're not in these roles just because. It takes a large amount of education, additional training, more education, additional training, experience, tenure, additional training, and so much to do the work that we do. And patience with the work, with yourself, with those around you, you know, and balancing things out. So I think it's a lot. Um, the other question that I missed, and you guys can kind of answer both and all whenever you guys want to unmute, but the other one I missed is someone asked about people who have lower IQs being more prone to it. Uh, I think I did hear at least two clinicians cover um, some of how cognitively we see correlations and things like that. But just because you have a lower IQ, it doesn't mean that you don't have um, adequate means of coping with distress. Now, can a person find themselves in situations that sometimes they react without thinking their actions through, and so those impulses take over because they have a lower IQ, because people are doing things to trigger them? Then maybe, yeah, but not just because a person has a lower IQ they are going to present with intermittent explosive disorder.
I think that just for a perspective, like putting something in perspective, under the neurodevelopmental disorders, autism spectrum is in there too. So think of someone that has ASD and think about how it is very hard to communicate their needs or wants. And think about, would I be angry? So am I angry because I have IED, or am I angry because of the symptoms of ASD where I cannot communicate or you cannot understand what I'm trying to say or do? So be careful. That's what I would say to that.
And then I'll just read straight from the DSM, because those are things that our Bible, as Dominique called it earlier, does talk about. One of the categories is prevalence. And I'll read straight from that in saying that intermittent explosive disorder is more prevalent among younger individuals. We covered that earlier. And it is more prevalent in individuals with high school education or less. Now, that's what it says, but I also want to add, like Dr. Jefferson was saying, you have to think about the situations that people in uneducated or not as educated situations, and think of the situations that they may be put in versus someone who seek higher education. So then it makes me think, is it the education, or is it the predicaments due to lack of education?
Right. So I think that's what I mean by situational. And then also, education level doesn't always dictate IQ, because you got some kids that are in elementary school with an IQ higher than a person that's a doctor. And obviously they have, tons of education, but their intelligent quotient is just higher. So intelligence isn't something that's measured based off of a person's exposures to education per se that's formal. Sometimes it's informal education opportunities, or their society and their culture, and what the customs and traditions look like in their family system, how they teach them life and things like that. So I think there is just so many levels to that. And then, like Dominique mentioned, people that are on the autism spectrum disorder, it's that spectrum, that continuum is so tremendous. And I tell people that all the time. You got people that are very low functioning as compared to societal functionality, and then you have people that are very high functioning as well. And so when you're looking to diagnose, you have to look at the way that whatever symptoms the person is presenting with affects the areas of functionality for them. And so if it decreases or mitigates their functionality in all of the functional domains that they're responsible for navigating throughout their daily lives, then yeah, you might be looking at that disorder. But if it's only affecting one domain of functionality, for example, they only present this way when they're in school situations with their peers, they only present this way when they're at home, then maybe there is something else that's going on in the home environment. Maybe there's something else that's going on in the school environment that's exacerbating the presentation of those symptoms. And so I think you have to look at the full picture, kind of like a lot of these ladies have already said. But we have to do our due diligence and help people to understand their diagnosis in a better way that helps them alleviate the symptoms that they present with, so that they can get back to living their best life as prescribed by them or discovered by them in therapy. So that's what I'll say to that. Does anybody else have anything else to add to the IQ question besides Jack? All right, so let's see. Make sure I get down to the next question. Did we do the question about I want to know if some people have this and don't know it?
Sort of, kind of, but I had something related to that, because when we think of explosive and we think of behaviors that come with it, we think of anger. There might be other words that explain this. And there's another question in the chat. I mean, it's right below it. It says, does this affect men with size issues more than women in sexual situations? Think about anger and what it's synonymous with. right? It could be frustration, it could be overwhelmed, it could be grief, it could be loneliness, it could be tired. I get hangry. Am I just angry? Or am I something else? Am I ashamed? Um, do I feel threatened? Am I anxious? Am I insecure? So
And
that's
yeah, and also like intermittent explosive disorder doesn't have to look like a person is expressing wildly erratic physical or verbal behavior. Sometimes people get so explosive that they shut down on the opposite end of the spectrum as well. And so when the question about does do people know it, half of the time when people are presenting with particular symptoms that are on the spectrum of a disorder, anything in their DSM, they don't know it. They're not doing it knowingly. They're doing it and because it's a part of what's shaping their basic behaviors in the various areas of functionality, or in response to learned behaviors and stuff from their system or whatever, family of origin, and during the process of rearing. So I think a lot of people present with symptoms of IED and they don't know it. They don't know. They have no idea because this isn't what they do for a living, for one. They don't care to know about it because it's not something that's in your everyday layperson education. I do feel like schools have got to do a better job at educating our children in the public sector about common psychiatric disorders and things like that. And in psychology, I think they should do that in middle school and elementary school and at a level, and I think they should do it again in high school. But that's a whole nother piece. And I do feel like people who have a smaller, if men have a smaller penis, that has a different implication than women who are struggling with sexual issues. So, to answer your question, the person that asked that question, if a man has a smaller or an overly larger penis, it's going to cause issues for him trying to engage in sexual opportunities with the women that he's interested in. So if a woman is having sexual issues such as dryness or loss of interest that leads to dryness, or what are some of the other issues that women may struggle with, or if her vagina has been stretched out too far and she can't feel anything. All of these things, all of them that present for women for the most part, are easily fixed. So they don't have a easy solution for topical solution for the issue that you're talking about with men that have a smaller penis. They also don't have an easy fix for a man with a larger penis. And so, yeah, if this is something that's preventing him from living his best life on a sexual level with the person that he's in a relationship with, I can imagine that he'd be more prone to explode than the woman who is having her issues and struggling through her issues, simply because there isn't an easy option to rectify the problem in the interim. So I guess that's my answer to that. But I wouldn't think it's intermittent explosive disorder either, unless that's the way that he's responding in all of those other functional domains. I think that some things are normal responses.
There is a long list of diagnoses under sexual dysfunction. So, like you said, not necessarily IED.
Yeah, but even that is not a sexual dysfunction to get frustrated because your penis is too small. It's not just not one. I'm a sex therapist, and that's just not in there. We don't have a disorder for that. I mean, it's normal for a person to get frustrated when things don't work the way they expect them to work in the situations they expect them to show up.
Some of the other things related to sexual dysfunction, not necessarily size.
Why'd you say it like that?
I'm
Poor
uncomfortable.
Dominique.
So I'm gonna mute. Yep. If I was a little lighter, I'd be good.
Oh my god. Oh my goodness. I just can't. Um does anybody else feel comfortable? Tanyetta, we talked about you becoming a sex therapist and coming on over into this realm of things. I know you got something you can say.
Um, I'm, I don't. I'm kind of stuck right now. I'm stuck. I apologize.
Oh my goodness.
Stuck right here.
Marquita?
I don't have anything to add. Since you called me out, I really don't have anything to add. I mean,
I feel bad. I gotta call you guys out though.
Dr. J is
but there's,
famous. I mean, she should have money for calling people out in uncomfortable situations. Sorry, Mark.
I'd
Go
say
ahead.
you think I'd be used to it, but I wasn't expecting this call out. However, I will say that there's a lot of different diagnosis. Like I said earlier, there's a lot of different life predicaments. There's a lot of different things that can cause people to get angry. It does not always mean that it's IED. You know, it can be sexual predicaments, it can be relationship problems, it can be issues on your job, it can be family issues. You know, anger and explosive behaviors present in a lot of different predicaments. So that doesn't necessarily mean that because he gets upset after or during sex that he has IED. Like Dominique was saying earlier, we don't want to narrow this diagnosis down just to presentation of anger, because anger is normal in society. And there we go with the normal word again. I try not to say normal, but anger is the part of our beings. It's who we are. It's okay to get angry. It's just, will it last too long? Or will the intensity of your anger get to a point that becomes dangerous to yourself or others? So, you know, whether it's about a sexual behavior or anything else, untreated anger or explosive behavior can be an implication of IED, but it may not be the criteria necessary to diagnose IED.
Right. Yeah. But so
yeah, I kind of took that off of just the sexual stuff, and you know.
Yeah, you know, but sexual things are a part of life. I feel like, you know, and I commend the person that asked the question. I feel like she's brave in the group that she asked it in, because they're having a large discussion around it now. A lot of people commented. I can't even begin to start talking
Can you
about
tell me
some of the
what
things
group
that are
that is?
there. This is yeah,
No, I'm just curious
about that life, Atlanta.
about that life Atlanta. Okay, ATL stand up. You know.
But I feel like this is what I feel. I feel I feel like sometimes there are situations that we have to use the word normal or norm criterion when we're discussing issues like this with people, because I feel like it does help people to understand that some responses, some behaviors in people are expected, but it doesn't mean that we have to accept those behaviors in our space if they disturb our peace. And so if his getting angry, or any of the other people that you've mentioned throughout your chat thread, because she's talking about it happening a large amount of the time. And the thing is, even if they're all getting mad at the same issue and it's the same issue, you have to give them space to be angry, frustrated, whatever they feel as a result to their penis size. We don't have a penis, and so I think that as women, we can't really talk about what that's like for them one way or the other. I mean, unless one of the ladies on has a male that wants to weigh in his perspective on it, I don't even know if that would be something that they'd be comfortable with. but the reality is, we could never know what that experience is like. And, I just, I'm happy I don't have one, I guess. I don't know. Never have to go through that. um, but so I think that it's normal for people to get frustrated when their sexual parts don't work, because sex is meant to be a pleasurable activity that takes away stress, and then so he can't free himself of stress. Let's put it that way. If his parts aren't performing in the situation that he needs it to perform in.
I
So
agree. I agree, Dr. J. And most men, they see their performance, it ties up to their ego and their
perception of self.
exactly. So if they feel
Mhm.
like they're not performing, they feel like a failure. So that in turn will have them to be frustrated and angry and upset, and the anger may come out in different ways.
Right. But so the other question is, the next one is, what if the other parent has this issue? How do I co-parent? I think Dominique said a mouthful when she said, "Let's just not put this on everybody." Lana, Lana, what?
Oh, go ahead. Sorry.
But what I heard from that was just how do you deal with it?
Right.
Not yeah, not like, oh, I know my baby daddy got it.
But then
But
again,
yeah,
diagnosing again, and we don't
yeah,
know if your partner has that. The only thing we can say, kind of like what we kind of roundabout said throughout all of us saying, is that you have to get the person to go to get counseling. Let them diagnose, not you. So
right.
we don't know if it's for sure, if your
But
person has.
yeah, and I will say though, if you just see these type of behaviors exhibited in a person that you're partnering with your child, I would just do exactly what I think the ladies have reiterated earlier, which is just communicating, trying to come at it from a supportive way, not criticizing, and, also just encouraging them to seek help and just kind of being there for them. And then also just making sure that you're keeping your child safe.
I think that's actually pretty good advice, Chanel. And kind of like what I talked about, the empathetic statements, it go a long way when you're working with someone, and they can be kind of pragmatic sometimes. You might want to use those statements to kind of help them de-escalate, and so that way you can get what you need out of the relationship and for your kids' sake.
So
I think that you start where the person is.
yeah,
If they don't want help and you've done what you can,
but they have to co-parent in this situation though.
right? Yeah. So you have to co-parent. So that's what Chanel was saying. Safety above all. You have to make sure you're safe and the child is safe. But it's like that old saying: you can lead a horse to water, but you cannot make them drink. You can be
Yeah.
as supportive as you want to be, but just also make sure that you're not more invested than the other person.
Or placating. I have to emphasize that piece. I feel like, cuz what I saw her just put in here is that she feels like she's walking on eggshells, and I see another guy commenting, and they're having a conversation about I guess a situation where he lost custody of his kids because of the perspective of the mom saying that he was overly emotionally reactive. I don't know you personally, and the thing is, if a judge enters an order, it's typically based off of a sleuth of information that they've received from the other party or other people who have observed behaviors, and sometimes from their own observations of who you are. And I have to also put out there that a lot of time, I know that you young people don't realize the value of social media and the internet, but stop putting all your business on the internet. You guys do more live recordings of you guys having altercations with other people, being disrespectful with other people, towards other people. And it's a lot of stuff that you put out there that's damaging to your character, and that they do use when they're looking at you in court cases for character references. So, um, so I say don't placate, and that's also, I'm gonna say that to that last comment before I read it out loud. Don't just say things are okay to a person just to keep things calm in the situation. If you have a problem with someone, if you have issues with communication, make it known. Speak your piece and get out of there. At least now it's known and you're not constantly standing there so that some type of altercation does happen as a result if you feel like they're volatile. But make it known that you really see an issue here in your communication patterns, in your interactive patterns, and that you have to be in this space to be able to adequately parent your child or children. But I feel like nobody deserves to be walked over and disrespected. You have to learn how to respect the people that you've laid down with. And that's something I teach my kids. That's something that I teach everybody. Because even if you don't like that person, you need to respect them. Because at one point you decided to tether your spiritual energy with that person's and to become a part of one another. And when you've made a child, you've done even more. So you have to be responsible in the aftermath of making these decisions, even if they were mistakes. And it's okay. Everything happens for a reason. Take the lesson and move on. So if you guys are having issues with co-parenting and you know for a fact that this is what they're dealing with and they've previously been diagnosed with intermittent explosive disorder, I say that they are probably already working with somebody to try and get that stuff under control. So bring it to their attention and let them know, hey, I'm seeing that there is still a lot of fallout, or I'd like to have better communication. Can we work on that without making them the identified problem? But that's all I can think of. Can you guys think of anything else for them to be able to say that would lead to them getting the right type of response that they're looking for and then move to better communication patterns?
I think that you were very accurate and thorough, and communication is key.
Only thing I would add is that if it's a possibility, if you know for a fact that they have been diagnosed with IED and you know for a fact that you have to co-parent with this person till this child turns 18, if they have IED and they know that, then they probably have a therapist. Think about doing some co-parenting sessions with their therapist. As I said earlier, it takes a system. The system has to be very supportive when it comes to treatment. The system has to be aware of your triggers. Sometimes it's going to take for the system to avoid your triggers. Co-parenting might be hard because maybe you're a trigger of, the opposite parent's IED. So maybe some co-parenting sessions so that you guys can discover some things about the patterns that you use to communicate with each other when it comes to the child. Maybe set some boundaries around the things that you actually communicate about. Whether, we're not going to talk about who we dating now, but we will talk about finances and these things. So, I would recommend that if this person has actually been diagnosed with IED and you have to continue co-parenting with them for a while, you may want to suggest or maybe ask and see if they're open to some co-parenting sessions with their therapist or a therapist of your choice.
And then don't be dismissive. Don't be dismissive or judgmental. Be open and curious, and be willing to be a part of the process without labeling them as the issue. Like I said earlier, I feel like sometimes the way that we go about things, it's not what we do, it's not what you say, it's how you do what you do and how you say what you say. And so sometimes you just have to be sensible in the way that you approach these things, because this is a person's personhood, literally, their character, literally, and that's something that anybody should be sensitive about. So let's look. My grandmother told me that if you have nothing nice to say, don't say anything at all. I feel like now this is what makes me like this, but my counselor labeled me with this. How do I get her to change my label like the lady Dominique was explaining? Dominique.
I don't know that I necessarily said change it. It just doesn't have to stick. So intermittent explosive disorder does not have to stay with you your whole life. If you have a problem with your diagnosis, though, it's the communication piece. I feel like, this is going on, but also you're not the expert. That clinician is. So I think that the best way to change it is change behavior. What is she documenting in your chart? What is she seeing, or not she or he? Sorry, you can have a male or a female therapist. But what is that person seeing that is a problem? And what are you guys collaborating on as far as changing that? And I think that might be the best way to change that diagnosis, is change behavior.
And I completely agree with what you were saying, Dominique. And I know that we've talked about this in several of our group chats about how a lot of therapists don't have the open dialogue, the open communication with their clients and their patients, and tell them why they're diagnosing them with whatever they are. They just either don't say it at all and just submit it to the insurance company, or they tell them this is what you have. And it needs to be a conversation of, this is why I'm diagnosing you with this. Do you agree? Did I miss anything? After hearing this, are you thinking like, oh, well, I did forget to tell you about this? Because that might, change the diagnosis a little bit. So I always tell a lot of my friends and people that I run into on a daily basis when they have issues with their therapist to definitely have that open dialogue, because if you're not agreeing with the diagnosis, your therapist should be skilled enough to explain to you, this is why I diagnose you with this. So they should be okay with explaining it, because this is what we do on a daily basis. That it should be nothing to them. And then just understanding that, and I'm not telling this person to change therapists or whatever, but it's just important to build solid relationships with your therapist and feel comfortable having these conversations and taking it there, because not just because this person takes your insurance doesn't make that the right fit for you.
I agree with that wholeheartedly. That was like, you said a lot, man.
This
So
kind
I feel
of
like you.
defensive a little bit, almost like, this is a problem between you and your clinician. And like Chanel said, like, you have that right to choose. I tell people all the time, if we're not vibing, that's okay. Use your voice and let me know. Don't just not show up, because I want you to get the help that you need. And if I can refer you or do something else, then let me know.
Exactly, because it's not about us. Like, the process of therapy is us facilitating space for you to, embark upon your journey of discovery, so that you can see those parts of you, recognize those parts of you that you may have denied yourself access to previously. But also, I feel like, a part of the process is, after you've made these unveilings of sort, you've unveiled some of this material, and now it's apparent to both you and I, as we navigate that journey and we have a really clear conceptualization of what's going on. If you think that there is a reason that this thing is going on, you think that there are some underlying reasons there that we've not explored already, let's talk about those too. And so it just looks like you have a better understanding, because you're allowing somebody in there a little bit more intentionally than you normally would. And you have to be open to the criticism that comes along with that, that process, and then be able to mitigate it, get rid of it, put it to bed, because it's only your criticism. It's not from us. We want the best for you in your experience.
And I didn't make these comments to be dismissive. And like, I just wanted to make sure that there was an understanding that you can't, like, you're not necessarily changing, but you're fixing some of the things that might be the problem. So you might not, a month later, you might not have those all those symptoms, and it might have decreased. So I just wanted to make that clear.
Yeah, it's not a lifetime diagnosis. Hopefully. Yeah, if you're working through it, if you're in therapy, you should be mitigating the symptoms over time. Um, and sometimes if you find that you're not getting anywhere in therapy, you need to be, that's a different conversation to be having with your clinician, and they should be doing constant assessing that lets you know that you are meeting your goals that you established at the beginning when you guys did your treatment planning, or you didn't. So, but I want to thank you guys for coming out, for dedicating your time, for submitting your questions, even the additional questions that are coming in and the comments. I thank you guys for having the vulnerability to start having these conversations and sharing with us, because at the end of the day, if you know that you have some of the behaviors that people are talking about may be a part of a diagnosis, you have to do your due diligence and get the help that you feel like you may need to just become the best, or a better version of the person that you want to be in your journey of becoming. And then I'll go over again some of the areas that our clinicians are listed. Chanel is in Maryland, DC, Maryland, Virginia area. So if any of you guys are up there, she's also servicing people in Florida and Jersey, right?
I will. I definitely Florida now,
Mm-hmm.
planning to do Jersey soon.
Oh, that's super easy. Super easy process. She will be. So, um, Tanyetta is in Wisconsin, also providing services to those people who are in Florida, Jersey, and she's LCDC in Texas as well. So she's also providing services for you guys if you need help in Texas. I know it's a lot of stuff that's recently gone on there. Lana is in North Carolina. She's servicing consumers that are located in North Carolina. Are you Florida yet?
No, North Carolina and New Jersey.
Okay, so North Carolina and New Jersey for her. And it's immerse counseling and consulting services, right?
Yes. Yeah.
Okay. And Dominique, you are in Indiana, but also kind of like on the borderline of Chicago, right?
Yes, I am looking to get, I'm going to expand my licensure to Illinois, Michigan, Kentucky, and Ohio. So be on the lookout for that. But also, Dr. J, I want to put out there, if you guys want to keep up with anything that I'm doing, just go to at IPCS Indiana on Facebook, Twitter, and Instagram.
There you go.
I want to throw myself out there. Help me reach my goal.
Yeah, that's right. Hit like, subscribe, follow.
Yeah.
That's right. Hit like, subscribe, follow, all of that, and also follow her. All of these lovely ladies have podcasts where this information is going to be featured, but also additional topics and information is going to be featured. So make sure you guys are following the links to the people's social media that I tagged on Facebook in the post. And Natasha is in Florida, and she's servicing consumers in Florida. Are you Jersey?
No, just Florida.
Okay, but don't worry, Jersey, she's coming. We know you guys need the help, and we're here to provide it. So they'll all be servicing Jersey by the end of the day. Yeah. Super easy process. So, and Natasha has stable kids counseling and consulting services as well. And Natasha works with young at-risk teens and adolescents. And so I think that the kids and teen population is definitely a vulnerable population right now. They're going through some very, very seriously intense adjustments in their lives, in their schedule. Uncertainty, anxiety, depression are not amongst the highest things that they're dealing with right now. I think most of it is adjustment disorder, and we're seeing a lot of these behaviors present in them because of what's been going on lately, and they feel like they don't have any control where they did have the little control that they had. So I feel like we've got to do our due diligence and help them along the process. So I feel like Natasha could definitely be a really good advocate for your kid if you're looking for a therapist for your kid. Dominique works amazingly with kids. I don't know how they do it. I just gotta take your hat off to those ladies. Chanel as well, and Marquita. She has that same level of patience, and my hat goes off to those that want to provide those services to kids. And Marquita is in Louisiana. Marquita, did you apply for Jersey yet?
I have not. I am licensed in Louisiana and Florida as well. But I am at Authentically You Counseling and Consultation Agency in Houma, Louisiana.
And these ladies do offer telehealth sessions. So you don't have to go to these different states to receive the services that you need.
We are certified.
Yes.
Yes.
So you don't have to worry about them showing up in their night clothes at all. So, or somebody just coming into your sessions, just coming in and out. You got lots of stuff that I think that you have to know, even though we think like these are common sense things, right? But no, you gotta. There are a lot of things that are contraindications of people participating in telehealth services. And I feel like when you're seeing a provider who is telemental health certified or board certified telemental health provider, I feel like when you're seeing one of us, you're seeing someone who recognizes and values the immense responsibility that comes along with making sure that we protect your information and confidentiality and your privacy. So that stuff is very, very important. I feel like you guys have got to make sure you're creating space for you to get the right type of help that you need from the right type of professional that you need, but more importantly, a professional that values those elements so you can make sure that you're doing so safely. Because the internet is a dangerous place, essentially. So, did anybody have anything else? So, again, I want to thank you guys for taking the time out and contributing to our content today. I hope that we have done you guys a service and been extremely helpful and informational for you guys. And if you have any questions or thoughts and reflections, I will be including each one of their social media content on the revised version of the video after the live ends.